Hey guys, we're going to be talking about today sedation in the setting of agitation, to sleep or not to sleep, how to sedate our patients in the emergency department that need sedation. So, to get our brain juices turning, some of the cases that I've seen are an 82-year-old demented man sundowning, a 32-year-old not so pleasant drunk guy, a 40-year-old agitated patient brought in by the New York Police Department, and Leo DiCaprio at the end of Shutter Island. All these patients, if they're in the emergency room, you may consider sedating them to keep yourself safe and to keep other patients safe. So the reason why we sedate patients is because not only for our safety and other patients' safety, but for the patient's own safety. Sometimes these agitated patients are agitated because of medical reasons that need to be addressed. So some important things that you need to keep in mind once you get the patient sedated are to work them up for things like alcohol withdrawal, stimulant intoxication, hypoglycemia and hypoxia are two big ones that might kill your patient. Neurologic reasons, thyroid issues, and then a diagnosis of exclusion would be psychiatric issues that cause your patient to be agitated. So what are the options to sedate patients? There are different classes of medications. The most common ones that are used are benzodiazepines, typical antipsychotics, and atypical antipsychotics. Most common ones that I've seen used are the top two, so midazolam or lorazepam. Midazolam is Versed, and lorazepam is Ativan. And typical antipsychotics like haloperidol and droperidol I see used a lot. And also for the atypical antipsychotics, olanzapine or Zyprexa are used. So one thing to keep in mind, the dosages, the onset of durations, the onset and durations are for IM medication. So if you give these medications IV, they'll act a little bit faster. So Versed IV acts, I would say, within 2 minutes from my experience, and droperidol acts much quicker than 20 minutes. So the best way to discuss which medications to use in which situations is to look at this graph from up to date. It looks super convoluted and like there's too much to learn, but if you zoom in on these central, I would say 5 squares, you will see that it's not that complicated. So let's take a look at them. So going from right to left, if you have a cooperative patient, you can give them lorazepam orally, risperidone orally, or olanzapine orally. So atypical antipsychotics or benzodiazepine, you can offer to them orally. You can tell them something like, would you like something to calm your nerves? You seem a little bit stressed. Is there anything I can get you to help you feel better? And most patients will actually be okay with just taking an oral medication to help themselves feel a little bit better. If a patient has a known psychotic or psychiatric disorder, you're going to want to go with typical antipsychotics, or you can go with a typical antipsychotic plus benzodiazepine. So you can go with haloperidol, droperidol, or haloperidol and lorazepam, the classic 5 and 2. Also, you can go with an atypical antipsychotic intramuscular, which also works well. One thing to keep in mind is that the dosages for haloperidol and droperidol are a little bit low. In the emergency setting, you can use a higher dose of each medication because 2.5 is not a very high dose. If a patient is intoxicated with a CNS depressant, you should avoid benzodiazepines because they can have a combination effect that results in respiratory depression. So you would give haloperidol or droperidol, a typical antipsychotic. If they're intoxicated with a CNS stimulant, you want to give a benzodiazepine because they're the treatment of choice, for example, for cocaine intoxication, and they have very little side effects. They have very little risk of respiratory depression, especially when used as an antagonist of someone who is very psychologically active. So you can use lorazepam, midazolam, or lorazepam plus haloperidol, again, the classic 5 and 2. In a severely violent patient that you have to put down relatively quickly, you have to sedate relatively quickly. My agent of choice is droperidol, but you can also use midazolam, or you can combine the two, or you can use haloperidol. And of course, right after you sedate the patient, you need to assess for different causes of the potential agitation, which are hypoglycemia, hypoxia, drug overdose or poisoning, infections, intracranial lesions. So these are a few pearls to watch out for when sedating these patients. And I've made the right part of this slide gray so that you can look at the left side and kind of quiz yourself of what are potential side effects of the medications on the left. So let's start with antipsychotics. You have to watch out for QT prolongation and neuroleptic malignant syndrome. With benzodiazepines, like mentioned earlier, you need to watch out for respiratory depression in alcoholics, or patient intoxicated with alcohol is what I mean to say. And with ketamine, you have to watch out for the emergence phenomenon, laryngospasm, and hypertension and tachycardia has a question mark next to it because, as we'll see later, these side effects are transient and essentially negligible because a patient that is acutely agitated, their sympathetic nervous system is so active that these changes won't make that much of a difference and are not risky. So what population of elderly patients should not get first-generation antipsychotics? And the answer is patient with Parkinson's, because patients with Parkinson's already have a low dopamine tone. So if you decrease that tone by adding a dopamine antagonist, you increase the risk of all the different Parkinsonian-like side effects of typical antipsychotics. Also, patients with high depressive tone from alcohol should avoid which class of calming agent? And the answer is benzodiazepines. So this is my step-up therapy for, like, you have step-up therapy for asthma. This is step-up therapy for an agitated patient. So stage one is patients that could be like an old demented patient, a drunk teen, mildly psychotic schizophrenic patient. You can use oral lorazepam or midazolam to try to calm them down, offer them something orally, like say, can I give you something to calm your nerves? That usually works. You can give them intramuscular olanzapine, or you can give them a turkey sandwich. And all of these options are great for calming down someone that is stage one agitated. Someone that is stage two agitated, they're disruptive without being dangerous. They're hard to redirect. They could just be simply intoxicated. You can use an intramuscular medication of 5 to 10 milligrams of haldol, 5 to 10 milligrams of droperidol, 2 to 4 milligrams lorazepam, or 2 to 5 milligrams midazolam. And you can choose to combine the typical antipsychotics. So you can choose one from the top two options and combine it with one from the bottom two options. And keep in mind these dosages, 5 to 10, are a little bit higher than what was on that graph earlier from up to date. And then stage three is excited delirium. This is a very dangerous condition that your patients are in. They're in a ton of sympathetic overdrive, and this can actually result in death in some cases. So with patients in excited delirium, you have to physically restrain them in order to give them their medications to make the environment safe for the other physicians in the room, the nurses in the room, or the police officers that might be accompanying this patient. But you have to keep in mind when giving the restraints, you need to be very careful. A way to hold a patient down, like a hog tie, hobble, or prone maximal restraint position, which is when a patient is on their abdomen facing down and someone is putting pressure on top of them, is very dangerous, and you should not do that. As soon as you can get the medications into the patient, you need to do whatever you can to take off those restraints and release pressure on the patient to avoid them from going into cardiac arrest. Also, a good pearl is to put high flow face mask oxygen on the patient. Not only does this fix one of the dangerous conditions that can be causing the agitation, like hypoxia, you also prevent them from spitting on you. And the drug of choice here would be ketamine. The dose you want to choose is 5 milligrams per kilogram IM. So if it's a 100-kilogram patient, you need to use 500 milligrams. And keep in mind that you might be afraid to use ketamine because there's sympathomimetic tendencies of ketamine, but these are negligible compared to the patient's native sympathetic response, so it's safe to give in a patient like this. And this is a summary slide of what you guys can choose or what I would choose in different levels of patient agitation. And I hope you guys learned something with this. And these are my references for all the information here. Thank you.